Welcome to Get Briefed Podcast, the latest MDBriefCase group offering developed to inform healthcare practitioners regarding a variety of relevant medical topics. This podcast is available at www.mdbriefcase.com. The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MDBriefCase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. Please enjoy.
I'm Dawn Rae Downton. Welcome to What is Chronic Pain Anyhow? Part of our podcast series for GPs and pain clinicians on how to treat chronic pain. So maybe you think you know what chronic pain is, and surely you know how to treat it, or you did, at least. Most likely over the last few years you've become less certain about that. There's been a real hairpin turn in our thinking about how to treat chronic pain after all, in the thinking of some of us anyway. There's been a lot of talk about it, but you might have noticed that the talk can be pretty one-sided. So we thought we'd take a shot at separating the facts about chronic pain from opinion about it. So let's start with the problem of chronic pain itself. What exactly is it? Is it acute pain turned chronic? Is it the inevitable sequela, trauma, or surgery, or some disease process? Surprise, at least a few aspects of chronic pain remain a mystery. We'll see if we can solve it today. We've asked two of Canada's pain consultants, Dr. Alan Kaplan and Dr. Robert Hauptman, to help us sort it out. Dr. Kaplan is a family physician in Ontario's York region. He's also a pain consultant and a clinical lecturer at the University of Toronto. Dr. Hauptman is a pain consultant practicing in Edmonton and an assistant clinical professor with the Department of Family Medicine at the University of Alberta. He's also one of the founding members of the Pain Society of Alberta and the Alberta Medical Association's Chronic Pain Section. Dr. Kaplan, Dr. Hauptman, thanks for joining us.
It's a pleasure to be back again. Hi, Don.
Hi to you guys, too. Dr. Kaplan, I'll put you on the hot seat first, if that's okay with you. Let me just start out by asking, what is chronic pain anyhow? Is there a definition that really tells us anything?
That's a great beginning, Dawn, because chronic pain definition is where this starts. We define chronic pain as pain arbitrarily lasting more than 3 months, but probably a better answer than that is pain lasting longer than one would expect it to in the natural history of healing of whatever the problem may be. And I think what we've learned over time, and especially with some work from a guy named Dan Brookhoff, who was a pathophysiologist who taught both Rob and I a lot of this work, is that the pain system itself actually changes, and then the body actually changes, and the neurologic system actually changes in the context of being continuously exposed to painful stimuli. That's a process called neuroplasticity. So the key thing here is that chronic pain is not just acute pain for a long time, it's a change in the nervous system.
So actually it's kind of a mistake then to think of it as a physical condition. Is that fair to say?
Well, I think, Dawn, I would argue, it's Dr. Hauptman here again, that it actually is physical, but the part of the problem, or the part of the physical body that's being affected is no longer, in most circumstances, the musculoskeletal system, the joints, the muscles, the ligaments, and so forth, but it's more the brain and the peripheral nervous system, what we call the central nervous system and the peripheral nervous system. So it would be a mistake to, as some people have attributed in the past, to think of chronic pain as a psychiatric illness. And unfortunately, sometimes when we think of the brain, the first things our patients think of is, the doctor doesn't believe me. This is more of a mental health or psychiatric problem. And nothing could be further from the truth that really chronic pain is a pathophysiological process within the nervous system itself that may have psychological or mental health ramifications, but fundamentally is still a pathophysiological change in the nervous system.
And to say that simply is that just because something hurts in a particular part of the body, that's actually mediated by the nervous system, not perhaps by the actual area where it's sore. That's an important distinction.
Okay, that clarifies things, and I think we're going to, in a little while, get into how chronic pain works in the body and how it can be followed and traced and that sort of thing. But for now, let me just go back to establishing the problem of chronic pain in Canada. Dr. Hauptman, I think you do know off the top of your head how many Canadians suffer from chronic pain and the trends that we're seeing in Canada when it comes to chronic pain. Can you speak about that?
Yeah, such an important question, because when you think of the diseases that physicians see in Canada, chronic pain is one of the most common things they'll run into. Depending on the estimates that you look at, the epidemiology, chronic pain affects anywhere from 20 to 30% of patients across Canada. And over the age of 65, it may be as close as 1 in 3 Canadians suffer from chronic pain conditions, usually in the musculoskeletal system, so things like chronic back pain, chronic neck pain, osteoarthritis. These tend to be the most common things people will see. But there'll be other sources, of course, particularly as people get older, things like neuropathies, diabetic neuropathies, trigeminal neuropathies, and neuropathic pain conditions, and even other diseases that sometimes are even more devastating for some of our patients, things like fibromyalgia, which is this generalized pain condition. And as you pointed out, this is a problem that isn't going to go away. As our population is aging, we are going to see more and more people coming to our offices with chronic pain conditions.
And we've been very successful, frankly, at treating a multitude of conditions. Our death rates from a variety of conditions have gone down. We see a lot of people who have been, quote, cured, end quote, from cancer, but end up with a lot of painful conditions as a result of either the cancer or the treatment, as an example. So being that we're successful in helping people get through all kinds of disease states, unfortunately, we're often left with a sequelae, which can be chronic pain.
So if chronic pain is associated with chronic illness, and chronic illness is are diseases of aging, more or less, does that mean that parts of Canada that have older populations, Atlantic Canada, for example, we're going to see more of that population in chronic pain than we would see in the population of British Columbia, for example, where the population is younger?
Well, that's a very intriguing and insightful question, Dawn. I think we likely could say yes, although I haven't seen any data to that point. But clearly, because we know chronic pain as a condition is more common as one ages, then I think that what you're saying makes a lot of intuitive sense.
I think we're also looking here at the rate, which is what you're getting to work compared to the total numbers. And being that Atlantic Canada, for instance, is a smaller province, perhaps the total number of patients may not be quite as large as a larger province like Ontario, although perhaps the rate of patients with chronic pain may end up being a little bit higher. But again, as Rob said, I don't know any actual data about that.
Right. Okay, let's go back to the question of what pain is. We touched on it before we went to talk about trends. I don't know if you'll understand this question, but what I want to ask is pain just pain, or are there different kinds of pain? You had mentioned the kinds of conditions that can give rise to pain, musculoskeletal being probably the biggest, or giving rise to the most pain that we have. But then that's not what I'm getting at. I think what I'm getting at is, are there kinds of pain in terms of how we process them in the body? So, for example, there's a kind of pain called nociceptive pain. How is that different, for example, from neuropathic pain?
Tremendous question, and a really important question for our listeners, because if we can differentiate the type of pain, it also guides us in our treatment. So we put this in big buckets, and the first big bucket is nociceptive pain, which is pain related to tissue damage. The next big bucket after that is neuropathic pain, where the pain is related to the nervous system itself and being transmitted by the nervous system. So an example of nociceptive pain, for instance, would be someone with a broken arm. Someone with neuropathic pain, for example, would be someone with shingles pain. Then there's combinations of both, and that's very common where you can have both. An example of that would be someone with sciatica, where you have pain from the back itself, but also pain from the nerve being pinched. The big picture, of course, when it becomes chronic pain, is the fact that as the nervous system changes, there's something called sensitization that occurs. And I'll let Rob describe that in more detail.
Yeah, so sensitization is really the pathophysiological change that happens in the nervous system such that subthreshold stimuli, or in fact, stimuli that do not cause tissue damage, result in a painful experience. So you'll often see people with chronic pain who are sitting in your office, they're looking comfortable, there's no triggers, there's no tacks in your seat, there's no, they're not being prodded by an electrical prod or anything like that. And you ask them to say, well, what's your pain from 0 to 10? And they'll give you an answer. Well, that's an example of sensitization of the nervous system. The pain system itself should only be turned on in response to tissue damage. And in the case of people with chronic pain who develop sensitization of the nervous system, they feel pain even when there's not tissue damage going on.
An example of that clinically is when you were to touch someone in a fashion of just brushing, and that provokes pain. So that is called allodynia, and it's a very powerful marker for someone who's got the nervous system hyperexcited and causing pain when it shouldn't be. Just touch should not cause pain, but when your nervous system is stimulated this way, that's the kind of finding you find.
Is this too simplistic a question? How would you turn that off?
Well, it's not simplistic, it's the million-dollar question. And that gets into the whole issue of how we treat pain from the beginning to the end. And I think it's going to be the subject of one of our podcasts, so we could probably fill the next hour for that. But again, very simplistically, it's going to be managing pain from the social, physical, environmental, spiritual things that we do to look after pain, which include all kinds of things from treatments medically to interventional treatments to just good cognitive changes.
I think what's at the heart of your question, Dawn, is why would a person with an acute painful condition ultimately go on to chronic pain? What takes somebody from something that's nociceptive and neuropathic, where we recognize damage to the tissues or the nervous system in these cases, and then they subsequently go on to have the sensitization problem? And that is the million-dollar question. We really don't know. We have some theories. We believe that there's some risk factors to this. But ultimately, at the end of the day, this is a bit of the holy grail of pain medicine, because if we can stop people from acute pain going on to chronic pain, we will solve some of the problems with this nation's issues with chronic pain disorders.
Okay.
There's a little bit of evidence, sorry to interrupt on, there's a little bit of evidence that shows that if you treat acute pain well, it may do a bit of a better job in preventing that chronic pain. So, one of the new rules of life seem to be in terms of limiting management with opioids and other things for acute pain. That may actually have a cost in terms of worsening our chronic pain numbers because of the undertreatment of acute pain.
Right, and I guess, is it fair to say, too, that given wait times in Canada, in much of Canada not getting any better than they ever were, and in some of Canada getting worse, are we failing there, too, in terms of managing pain better by not getting to treatment of acute pain promptly?
Yeah, I think that's a fair statement, Dawn, that we do have these longer wait times for acute and chronic pain services, and I think that contributes also to this evolution, people not getting the services they need at the time of those acute injuries. That being said, how we treat acute pain isn't necessarily that well elucidated and well taught in medical school. So I think part of the problem still goes back to the poor primary care physician. You see somebody come in with either an acute injury or post-operatively, and knowing how to manage that patient when they're coming in complaining of pain is problematic and not necessarily well understood by many physicians.
Okay. We know that the causes of pain basically fall into three areas: illness, pathophysiology that comes from illness, and also from trauma and surgery. I want to ask about idiopathic pain, pain for which there seems to be, or perhaps is, no cause that can be determined, or perhaps doesn't even exist. Is that different? Is that kind of pain different from what you were talking about earlier in relation to oversensitizing the system so that pain just sort of develops a mind of its own? If that's probably not a great metaphor, but you know what I mean. Is idiopathic pain different somehow? Can we talk about that?
Well, idiopathic means that it comes for no reason.
Right.
Just because we can't find the reason doesn't mean it's not there. So I think that's really the important thing, and I don't think we need to label idiopathic as an important cause. As clinicians, we'd like to have an explanation. So it makes sense to me if someone has an outbreak of shingles and then develops pain along that spot, for them to have pain there. It doesn't make sense to me why a person would then have pain outside of the area where the shingles were, for instance, because that doesn't make sense pathophysiologically in the normal anatomical way it would work, because we know shingles pain gets transmitted along a nerve. But we also know, as Rob has said, is that the nervous system changes and gets sensitized, you get pain generalized to other areas. So just because we don't know what started it doesn't necessarily mean there wasn't a cause. Fibromyalgia is a good example of this. There's been a variety of reasons that have been shown to cause fibromyalgia, and that can be a life event, that can be a psychological stress that then induces this painful stimuli and has nothing to do with a physical event. So once again, idiopathic is something we talk about in school as a bucket, but I don't think that's an important place. I think what's important is for us to recognize that it's there, assess the person properly, and then try to help them with their problem.
Yeah, I couldn't agree with Dr. Kaplan more. I think the term idiopathic pain used to be used a lot in the past. I rarely would consider my patient's pain idiopathic. Virtually all the individuals I see in my consulting practice have had some sort of event that have led them to go on to develop a chronic pain condition. So there's always a valid cause, and rarely do I see pain just start de novo out of the blue and then the patient presents.
And the danger to calling something idiopathic is then that it's perceived as not being real. So I'll say again, there may not be a cause that we can find. That doesn't mean the pain is not valid and requiring treatment for that individual.
I'm glad you said that, Dr. Kaplan, because I was going to come back to your point earlier about pain in the brain as opposed to, pain in the peripheries of the body. If a physician can't determine that there is a connection between an acute event a long time ago and chronic pain in the present, if there's been, a big gap or somebody doesn't recognize what the trigger was, the patient perhaps doesn't recognize, so the physician doesn't get the opportunity to put two and two together, does that not leave the patient in the unfortunate position of being suspected of it all being in his or her head?
I think, Dawn, this does happen, unfortunately, more than we like to admit, this labeling. And I think when you talk about buckets, probably the biggest bucket we use in medicine is the mental health bucket. And that is this feeling that if we don't understand anything, then it must be in the realm of psychology and psychiatry. I am of the opinion, and I believe Dr. Kaplan shares this opinion, that chronic pain is, again, a disorder of the central and peripheral nervous system. And so even though, as Dr. Kaplan put it, we may not recognize what that initial event is, we know the nervous system has changed. And you can objectively demonstrate this, either through radiological techniques. We know you can demonstrate this now with functional MRIs, some of the changes that happen to the brain with chronic pain, or simply through physical examination. Dr. Kaplan has mentioned one physical sign that's objective and reproducible called allodynia, this sign where non-painful triggers give a painful response. There's another reproducible physical sign, and that's called hyperalgesia. That's where a lightly painful trigger causes an intense painful response. So these are objective, they're reproducible, and they are our example where they tell us that there are changes in the nervous system.
Rob has also described to me a number of times a condition that he describes as temporal summation. I think that's probably worth sharing.
Temporal, what was the last word?
Summation.
Summation, yes.
Summation. So temporal summation is a clinical sign that, again, is objective and reproducible and is a reflection of nervous system dysfunction. And this is where you take a lightly painful stimulus and you repetitively tap or induce a response on the area that's painful in the patient, and you ask them to tell you how much it hurts from 0 to 10. And in a normal person, when you're actually tapping them with a lightful, painful stimulus, they may say it's 1 out of 10, 2 out of 10, but it doesn't really increase exponentially. In chronic pain patients, over the area that's painful, it'll start off at 2 out of 10, then 5 out of 10, 10 out of 10, and then they actually wince away. So this is a very reproducible sign. Again, not reflecting something that is psychiatric, because it seems so weird, but rather something that tells us there's a pathophysiological change in the nervous system. I'll give you one other quick example, because I think this is so important. I often get clinicians who come up to me and say, Dr. Hauptman, when I take a blood pressure on somebody with fibromyalgia, they get very upset. They wince in pain, or sometimes they actually vocalize in pain. And they'll go, well, isn't that weird? This must be a psychiatric problem. And no, that's just, again, another example of this reproducible sign called allodynia. When you pump up the blood pressure cuff, it creates a stimulus that the patient's nervous system interprets as being tissue damage and pain.
Okay. I think our people listening might be interested to know. I certainly am. You had mentioned that you see imaging changes in chronic pain patients on fMRIs and other indications of chronic pain, the ones you've just described. Are those reversible? Let's just say that somebody beats his or her chronic pain and gets better. If you fMRI'd that patient again, after her or his recovery, would the brain go back to what it had been?
Well, yeah, this goes back to what Dr. Kaplan was saying about neuroplasticity, and we are really interested in mechanisms to try to revert that brain back to normal. And there is some evidence. There at least one published trial that I'm aware of, looking at a multidisciplinary tertiary pain clinic where they took patients prior to the program, did functional MRIs of their brain, and then subsequently after the program did functional MRIs of their brain. And what they found was their brain did start to revert to a more normal pattern. Now, there wasn't a lot of long-term follow-up in that study to say, okay, what's that going to look like 12 months down or 18 months? But we are convinced that there are some treatments, and we'll talk about this as the podcasts go on, that may have a healing factor on the brain and the ability to possibly revert some of those negative changes that we see in chronic pain.
And just to add to that, I don't want our listeners to think that these functional MRIs are a test that they've been missing and haven't been doing. We can't get those. These are tests that are only done in very special settings and an experimental setting. We can't get them. But I think it does make sense that if we can reverse what's happening in the brain, we can make some changes in the imaging. I think what's also important is the fact that the brain does change in other ways as well, not just because of medications, but sometimes just because of the cognitive ways that people deal with their pain. And some of the biggest successes I've had in pain management are the patients that have made the decision themselves they're going to change how they live their life and how they deal with their pain and how they interpret their pain. And therefore they can live a different way and therefore not suffer with the pain. So remember, the pain may be the same, but the issue really is how much they're suffering with the pain as the problem.
Can you give us a little more detail? Can you drill down a little bit about what those patients do to change, how do they think about their pain differently? I mean, what's the process there? Give us an idea.
Yeah, so I wish I could say this is easy, because it's not. It requires a lot of insight and a lot of hand-holding and a lot of communication and a lot of care by the clinician. But it starts with a good explanation of the problem. It starts with understanding that the pain is real, the pain occurred for a reason, that the person themselves has lost the distinction between the effect of the hurt that's occurring versus the harm from the presumptuous bad issue that's causing the hurt in the first place. And then from there, the often deterioration of the quality of life and so on that the patient goes through because of that pain. So the education about the fact that this pain, albeit there all the time, is no longer causing harm, and understanding that is the first step. And then with the support, both physically, psychologically, spiritually, and with whatever medications or interventions are required on top of that, to then allow the patient to get some relief from the pain, then allows the person then to believe and understand that, wait a minute, this can get better, I can move on with my life, I can have good goals and move towards them. And eventually it's just an issue of this is a painful stimulus that's not causing me any damage. Can I actually learn to ignore it? I give some examples on this, and the examples I give are twofold. One is music in an elevator. And some people get into an elevator and the music is going and it makes them crazy and they stick their fingers in their ears because they can't stand it, whereas other people don't even seem to hear it. And that ability to sort of turn off the music, in this case turning off that painful stimulus, is one. The other example I have is if anyone's ever been skunked in the audience. So I've got dogs and they've shared with me their skunks a few times, unfortunately. And a skunk smell is a terrifically uncomfortable situation, especially when you get up real close to it. However, it doesn't harm you. It, quote, hurts you, end quote, but it doesn't harm you. And eventually you get desensitized to that smell so that it no longer bothers you. It may bother the people you're in contact with, but it no longer bothers you so much. So that's the kind of overall idea I'm trying to talk about here in terms of learning to deal with your pain a different way. And that requires an awful lot of care, compassion, and as well as insight in the patient to be able to move on.
So one other way to look at this, Dawn, really quickly from my point of view as a pain consultant, is I'll often talk about the difference between pain and suffering. So while the pain is, for most of these people, not optional, it's not something we can cure, suffering, on the other hand, is optional. It's how we respond to the pain. So sometimes simply getting a person to walk for 5 minutes or getting them to make a goal of, hey, you know what, you can maybe watch your granddaughter play soccer for half a period or something along those lines, start to give people control back and start to reduce their suffering. Their pain might still be there, but their suffering is reducing, and this is quite important in terms of treatment of chronic pain. And again, I'm sure we'll cover this more in later podcasts.
Yes, yeah, we will. For now, I think the question that might be in some people's minds, and I think will be greatly in pain patients' minds, is it realistic to think that it's possible to stop noticing suffering when you have really severe pain? Say you're a patient who's, identifying himself as number 9 or 10 on a pain scale most every day. Is it realistic that patient can, I don't know what the word is to use, disconnect somehow, emotionally disconnect from the fear of that pain? I think it's the fear.
Sure. I think, Dawn, your point to the question, I don't think the expectation from myself or Dr. Kaplan is that our patients are all of a sudden going to have 2 out of 10 pain or 3 out of 10 pain, or let me go back, or that they have to live with 9 out of 10 pain. That's probably more your question.
Yeah.
I think it's a process going forward that if we do everything right, if we focus on cognitive things, if we focus on lifestyle issues, if we focus on medications, and we balance these out over a period of time, most patients reduce their suffering and also reduce their pain. But their pain's not going to go to zero. That's where I'm saying, again, pain itself is probably always going to be there, but suffering may not always be. That's what we're trying to kind of reduce. So I'm not expecting somebody with 9 out of 10 pain to just ignore it. I don't think I could ignore 9 out of 10 pain. But the good news, the great news of chronic pain management, which I hope to get into in the podcast, is that with what we can do today, we can reduce that pain intensity down, we can reduce the suffering.
Okay. I think what's really important is to recall that we have many, many tools to do this. And Rob's listed some of those tools now. But at the beginning of this, we talked about the whole issues about some of the changing outlooks about pain management out there. And in some places, this has become a dirty word, managing pain, and doctors are now afraid to manage pain because of sanctions and rules and colleges and things like that. Well, we have many tools, which include adjuvant therapies, interventions, opioids, and if you use those effectively, efficiently, and the right people, we can help our patients go a long way along all the things we just talked about.
And possibly use them together, integrate them together, although we don't have enough of that happening in Canada. I'm not even sure it's happening anywhere, but it would be good, wouldn't it, to use them all together?
Absolutely. I don't think either of us, I think the folly of pain management in the 21st century is the belief that any one intervention is the answer. I would be surprised if any one patient just did one thing and that's going to get them better. It really requires an open mind and a flexibility looking through all the therapeutic options that may be applicable to that patient, individualized patient care.
Complementary things that work together, and use the right thing for the right person.
So we need some of that in Canada. You'd agree?
Yeah, I would agree. I think, again, we need to continue not only at the primary care level, but at the the tertiary pain levels as well. We need to kind of have that, because I believe the primary care physicians are in an ideal setting to be able to do that for a lot of patients. I think it's only the minority of complicated pain patients that need to end up in tertiary pain clinics. I think that family doctors have those skills. They apply those skills, for example, to diabetics that require a multidisciplinary approach. They apply those skills to people with asthma and COPD, these multidisciplinary skills. It's not just all about a pill. So I think what we need to do, and I hope this podcast is going to do as well, is empower family physicians to get excited about their pain population again, use the tools they have to help these people, and when they are, they're struggling, then we can get them off to one of the pain clinics, one of the tertiary pain clinics.
And then maybe the waits won't be so bad.
Great. Just one last thought that I have. You've talked a good deal about chronic pain and how to mitigate its effect on patients' lives. I'm just wondering, because acute pain is often allowed to become chronic in this country, is there something that a really savvy patient could do when she or he is injured, when she or he gets sick and falls into pain? Is there something that patient can do at the point where the pain is acute to prevent it from becoming chronic, or at least to, if it becomes chronic, make it less painful?
A really good question, and I'll try to give you some kind of answer, and I'm sure Raul will have some comments as well. I think to start off with, it's making sure that you understand what's the matter with you. You understand the good and the bad about the problem. You understand what's harm and what's hurt, as I've already alluded to. Understand that there is things you can do about it and what the limitations are. To be able to deal with what your fears are about that problem. That's probably the most key thing. What is it you're afraid of? And we do see a lot of people that we can sort of predict are going to have a longer pain course because of their expectations of their outcome at the beginning. We also have personalities in patients that also may tend to lead to them having longer pain issues because of the way they look at things. So a good, frank conversation early on can make that big difference. I'm reminded of a patient of mine who I knew his father who had chronic pain, and this young man got into a motor vehicle accident. And knowing they were from the same family tree with the same thought process, I very early on sort of cajoled him, threatened him, promised him that he did not want to end up like his father in that kind of situation where his life only turned around his pain. And it got bad for a while, and then it got a lot better when he decided again that he wanted to move on from this. So we can make a difference to this. We can change things in this a little bit. But reality, it's a combination of good acute pain treatment and good understanding, and understanding what you're afraid of and dealing with that up front.
The other thing from my point of view is movement. Early on in an injury, the more we can move, there's pretty good evidence that helps the nervous system to heal. And unfortunately, one of our old paradigms when it came to injuries was bed rest. Don't move. So again, a savvy patient who has been in injury, if they can move as soon as it's comfortable to do so, and get a physiotherapist, a good physical therapist, who is not just all about their gadgets, but hands-on, is going to assist the patient in movement. I think this is also very important. And I cannot underemphasize Dr. Kaplan's point of addressing fears early on, because unmet or not addressing these fears, again, is something that can sensitize the nervous system and lead on to a patient developing chronic pain.
Let me give a quick example, Dawn, about this. I just had shoulder surgery done, and I'm watching other patients who've had shoulder surgery done around the same time frame. And my approach to it was rehab it as early as I could, as fast as I could, only being told to take care by my surgeon not to overdo it. Whereas other people are afraid to move at all post the surgery. And they obviously had a worse time of it than I did afterwards, because not moving it leads to stiff shoulders and then more long-standing pain. So to Rob's point, getting movement back, getting your life back is really what's important early on.
Right. And I'll tell you this story. I had a knee replacement about a year ago, almost exactly a year ago, and I moved as much as I could beforehand, and they make you will know this, but I didn't, was horrified to find out that they make you get up and walk around as much as possible, and then the minute you get home, they tell you to sit somewhere where you can swing it and just keep it moving and moving, and I had a really fast, good recovery. I was amazed. I just had no idea it would go that well. I expect a lot of it had to do with observing the kinds of principles that you guys are talking about. I did want to pick up one thing, was when you were talking about how people's personalities can contribute to the outcome with their pain journey. I used to talk about myself again for just a minute. When I was younger, I had a lot of migraines, horrible problem with it. A neurologist said to me one day, and he was joking. It was good that he was joking, and I knew him well enough to know that he was. Otherwise, I would have clocked him. He said to me, "Oh, you're early again." He said, "It's so typical with migraine patients. You're all early. You're all type A." You remember when we had type A personalities and type B personalities? Remember when we used to talk about those things and we would say type A people have more heart disease? Well, type A people, according to the neurologist jokingly, had more migraine. I think patients get very offended by that kind of, by being told those sorts of things. How is that different from what you're saying about how people come at their acute pain and keep it from becoming chronic pain, or at least keep it from becoming bad chronic pain? How do you deal with? I guess what I'm asking is, how does a doctor tell a patient what the sorts of things that you're telling me without offending the patient?
Yeah, I think that's a good point, but I think we really want to be clear as we're talking to health care providers on this podcast that, what can we recognize that might be a factor that may lead them down that pathway. So you're born with your personality. Nobody should ever be blamed for the type of personality they have. Some people are more stoic. Some people are more emotional. Some people are more optimistic. Some people are more pessimistic, and so on and so forth. We don't sit there and should not ever, as healthcare providers, play the blame game. However, it is so fundamentally important for primary care physicians and people who look after people with pain, particularly acute pain, to try and recognize those patients who have personality types that may be a bit more emotional, or what we would call catastrophizers, people who kind of ramp things up and everything is the worst possible thing that might happen to them. This is, again, not to blame. This is rather to recognize that this might be a risk factor for them developing chronic pain. And the point of the clinician is not to turn to the patient and say, I think you're being very emotional, very catastrophic. I mean, that would be ridiculous. But rather saying, hey, this has really affected you. I can see that this injury has caused a lot of stress. What are your fears? Let us talk about those fears. And maybe in some cases get a psychologist involved. And again, selling it by, no, I don't believe this is not real, or it's not that's in your brain, but rather, this obviously has affected you greatly. Let's get a professional to help you through this.
Yeah, that's a great idea. I'm struck by the thought that probably family physicians in Canada in 2018 are not going to have the time or energy to treat patients that closely, that densely, and to make a referral to a counselor would probably be a good idea. But then there's wait times for that. But all these things are.
So, Dawn, I'm going to interrupt you there.
Sure.
Because you just tread into an area that I feel strongly about.
Sure.
I think family physicians have the capability of doing every single thing we've just talked about, including counseling their patients through difficult times.
In a 10-minute appointment?
I do this every day of my life, and every single patient that I see. Some of them get longer times, some of them get shorter times, some of them get more frequent visits, some of them get less frequent. It's often dependent on what they want to do, not what I want to do. So, just in terms of, there's almost a blame game going on there to the family doctors, which I want to caution, especially as our listeners are probably going to be mostly family doctors. I think what's important is to recognize that there are patients who look at things differently. So the analogy for the shoulder is a perfect one. Nobody had to nag you to do physio. No one had to nag you to do physio. You were aggressive in doing it. There's other people that are passive and won't do anything because they're afraid to move because of it. In back pain guidelines, we talk about red flags, which are things that are dangerous, means there's an underlying problem that's dangerous, such as cancer or infection, and yellow flags, which are personality types and more important, behaviors that predict bad outcomes. People who do not exercise, people who expect someone to make them better. And that's just something that people do. Now, how we can make sure that doesn't happen is by saying, hey, I'm seeing that you're not taking ownership of your problem well enough to get better fast enough. Would you like to understand how we can do this better together? If they have enough insight to say yes, we have success. If they don't, it takes longer. And the analogy I gave you of the son of the patient with chronic pain, he was a yellow flag kind of person, and actually it was explained to him why he was going to get into trouble because of that, made it successful for him to turn the corner. So bottom line is, this is not blame. We're not talking about that. We're talking about allowing our other healthcare practitioners who are listening to this to understand that you ask for predictions early on, who are the people that may be more likely to get pain? Well, the ones who want someone else to fix them versus them taking ownership of their problem and doing everything they can are more likely to have more long-standing issues, be it pain or any other medical condition that there is.
Okay, that's good. That's terrific news. So the patient does indeed have some control over his or her pain and future. That's really good to know, and it's good to know.
They do need help. They do need help, and they do need help of the people listening to this podcast to recognize this early on and to guide them, and for their family to guide them, and their friends to guide them, and their supports to guide them through this really difficult journey they're going to go through.
Okay, and this is this kind of information is getting out to family physicians. They understand that they should have this kind of conversation with patients.
I think this is probably done some of the important part of this podcast. And what we try to do, Dr. Kaplan and myself, is we go across the country. We've spoken to many family physicians about the proper treatment of chronic pain and recognizing some of the risk factors for acute pain. It is a journey for educators as well, and we're just starting that journey, and we're hoping for support from universities, the College of Family Physicians in Canada, but we're making some progress, and it's hope with some of the support with things like these podcasts, hope to reach out to more family doctors to empower them to not look at this patient population as, oh no, not another pain patient, but rather, hey, these are people that not only we can help, but we do have the skill sets to help.
Wonderful. I hope a lot of family physicians listen to this. This has been great. I guess to sum up, it's obvious we can't know how best to deal with something unless we know what we're dealing with. So if we make the effort to find out, and we do that patient to patient to patient rather than imposing formulas on people, and also involve the patient in his own progress in a way that patients might not realize that they can, then that's the way to go. So thanks very much for all the great advice here. It's been an eye-opener for me, and I imagine it's been an eye-opener for listeners. So thanks, guys. I want to mention that Dr. Kaplan and Dr. Hauptman will be with us again next time when we're going to be looking at assessing pain. They'll be going through everything you need to think about that step by step, and you won't want to miss that one any more than you want to miss the one we've just heard. I'm Dawn Rae Downton. Thanks for joining us, and we'll see you next time.
Thank you for listening. If you like this episode and want to hear more, please visit www.MDBriefCase.com and subscribe to the Get Brief podcast channel. Tune in next time for another exciting episode.